Well, I don't know.
But I don't know. It's good. Is it going well?
Yeah, so far so good. I think I've been in this post 3 years now. When I left practice nursing to go to hospital on a 12-month contract, my mum were like nearly having kittens. Melissa, you can't give up your job. You've got your kids, you've got your mortgage. I like it'll be fine. And so far so good. It has been fine. I can't
Yeah.
complain.
So are you? I'm still getting my head around it, Melissa. So what? How do you get your people that you deal with? How do you get referrals
Because
or?
well, I've got a contract with the PCN, the 12 practices. So the PCN pays my social enterprise. So I just work across all them practices. So I use data to identify my patients. I've done lots of different things. I was doing training and updates for doctors and nurses, joint clinics, working on projects,
Yeah.
cost saving. I've saved lots of money prescribing stuff.
Oh, right, okay.
And then, like with COVID, I've been focusing on the high risk patients, making sure they're optimised. Just variety. I've been making it up as I go along, really.
Oh, no, it sounds really good actually. Yeah, it links a lot of things together. I think from what you say, you're like
Yeah.
a common thread between all the practices.
Well, I've got Lisa here with me as well today. This is the reason why I'm on the call, because we created a new role for Lisa. So
Mm.
Lisa's our new integrated nurse. So she's joint funded by the PCN and LCH. So she's actually coming to work for the population. So she's not working for the practices or LCH. So trying to that mind shift and set with people, trying to get it into the minds that no, she's not coming to do a 2-hour clinic for you here. She's not coming to do that for you. She's going to be working on projects for our
Yeah, yeah.
population. So that's really
Good.
exciting.
Oh, it sounds really good. Good luck with it. Let me
Hi.
know how you get on. It sounds like you say, there was a need there, and you sort of identified it, and it's just getting that moving, isn't it? That's
Yeah.
really good. That is a bit like population health management, but like done the other, like you saw the need without actually having the population health management statistics, but then took it forward as a project, and now it's where it is. So you could argue that that started 3 years ago for your population health management.
Yeah, I guess so. Well, I think it's well for Lisa's role that were recent, but like for the respiratory thing, that came even before I set up my social enterprise. But looking at data, the atlas of variation for respiratory, like in Leeds, we were rubbish, and
Yeah,
there's that much variation in practice. Well, why could you go down the road and get 30 minutes quality review, but then you're going in that surgery there and you're getting 10 minutes of ticking boxes? Like to me,
yeah, yeah,
it's
yeah,
just not right. So I've always been passionate about trying
yeah,
to improve things.
yeah. And I suppose the area that you work in is a high incidence of respiratory problems, I presume.
Yeah, yeah. We have high everything. High mental health, high drug use, high poverty.
Yeah,
Um, challenging area to work in, but that's the kind of stuff what I like. I like a challenge.
yeah, no, it's really good. It's really good.
So Melissa, are you so we heard from a couple of people already today about kind of non-medical interventions. We keep creating, services for folks. So how are you signposting? Are you kind of
I am
signposting people
the
around?
most holistic nurse I think what you could ever meet. Um,
Right.
like my patients get informed about meditation, exercise, using handheld fans, losing weight, whatever. I am really, and then I've always took on board the mental health, referring to mental health teams or social prescribers. In my job here, when I worked as a practice nurse, I developed a role for a social prescriber before social prescribing was actually a thing. So we had a worker here doing stuff like that. I refer on to everyone, and I look at everything: the mind, body, soul, social, physical, mental, because you have to. you know, that people are holding on to a lot of stuff, what's causing, and as soon as you tap into that, it just makes a shift and makes a big thing. So yes, I'm an advocate for holistic. I refer on to everyone, and that's
Excellent.
how I am.
And so kind of we're all in a data room. So how are you? So you know, we've spoken before about identifying your patients, and I assume you get referrals from various your
Yeah, so well,
GPs.
before COVID came, I was doing a hub on a Friday. So because I can't get round all the practices, on a Friday we had a hub where they could refer all their complex patients in or whatever they wanted me to do. But then on System 1 there are some different reports where I could find patients, but I always felt like it's been difficult. I've really had to go out and search and find and try and but there's some new reports what have come out, what you guys might want to know about from University College London, because they're bringing them out for diabetes, hypertension, all different kinds of stuff. But I asked Data Quality to put the respiratory reports on, so they've been on there a few weeks now, and so it helps you risk stratify your asthma patients and COPD patients, and they've grouped them into 3. So then reports are already on System 1 for the respiratory. So you can target your high-risk asthma patients, your high-risk COPD, and so they've got 3 different groups, so it helps with risk stratification. Yeah.
And and then how? So back to that question. How do you know you're making stuff better for those people that you're seeing? What's your
Like,
what are your measures, or are you using clinical outcomes or just kind
Well,
of
a bit of different things, because like obviously when I first started I needed baseline data, so that were really hard to try and get baseline data from people. Then trying to get follow-up data again was hard, because we're not commissioned to do that now. I just got so many different things. But I managed to get some prescribing data, so I made a poster last year for a respiratory conference about how much we'd saved. That was the only thing really. But like I do family and friends test. I made my own thing up with patients, so getting qualitative data as well as quantitative data. But yeah, I found that like trying to get data and stuff has been really hard, but I know the importance of it. So because I'm like a social enterprise, I wanted to prove my worth and prove that I am making a difference or whatever. But it's not been easy, and I found it really frustrating, because I think, well, if you as commissioners commissioning services, why are you not holding people accountable or responsible, or why are you not? Do you know what I mean? Like, it's taxpayers' money, we're paying for stuff. We don't really have a clue. Sorry, I get right passionate about it because I hate waste, and there's stuff out there. What is a waste, and no one's like made accountable for it.
We struggled in the beginning for my role to actually find a cohort of patients to concentrate on, and we went all over. My role was advertised as I'd be given these cohorts of patients, but it hasn't really been that. We've been searching for them and come across them incidentally, really, with the COVID situation. I've been ringing carers, so we've run a report on carers, and I've checked that the health screening's all up to date, found that a lot of people's wasn't, got them booked in for appointments, referred people to smoking cessation and things like that just over the phone, and social services by people. Some people were in crisis, a lot just didn't want to talk to me, but I have made a difference in some people's, like, small differences. So but it's hard to find these cohorts of patients. That's sort of the barrier that we've been up against a little bit.
It might be better for us, like, once the quality improvement scheme comes out, because there's going to be lots of work for her in there. I'm not saying there ain't work for her, but it's not as easy. We've not had an easy ride, have we, anyway? But we don't give up.
We've got a lot of work with the flu, actually. We're giving flu vaccines to the housebound and the care homes, which obviously sit between LCH and the PCN. So we're streamlining the service a little bit so that obviously it frees up the district nurses and the practice nurses if I concentrate. So we've done some planning, which has took a lot of time on it, to postcode the areas, and then obviously you've got all the PGD and things to sort out. So it's we've done a lot of work, but I feel like, because I came from the virtual ward at Bradford, so it was physical work in acute services. So I've had to learn primary care and the Leeds Community Health as well. So, and I've only been in post 5 months, but so.
Lisa's got a hard job, I think, because, you know, like we've been talking about systems leadership and all this kind of thing, you know, because she's part funded by the PCN and LCH. Everyone's got their expectations. They don't really understand the role because it's a new role and working for the population. It's about trying to get into their mind that she's not for your practice, she's for the population.
Yeah.
It's just like, and then, you know, she's gonna go beyond that with council, and so
Yeah.
she's gonna have fun, but it's all the different people to, you know, everyone's got different perspectives, haven't they, and expectations.
And doing everything over Teams is brilliant, but I have missed meeting people face to face, really, because I think you can gauge people better face to face, you know. But
I think that's a really good point that you make there, and I think one of the things that we've noticed as well from the, and this is from feedback, it's not just noticed, this is from feedback from the local care partnerships across Leeds, is just those 5 minutes informal gabs that you'd have with people before a proper LCP meeting or the full meeting, or that little kind of spark that gets lit within a meeting, and then you catch someone after the meeting, and those connections that get made, and I think that come through quite strongly in the stuff that we've spoke about this morning, really, about how important that is. So yeah, it's one of the things that unfortunately it's kind of we're missing at the moment. No, I certainly miss it.
I know, I do. It's a good job I had Lisa, I was on a cracked up, because I've got to phone the patients now. You know, I miss my clinic, seeing them in, even, you know, you'll see a patient, you'll walk up to end at corridor and get them, and you'll see people and walking around, just chit-chatting to people. You just sat in a room, it's just like,
But that's going to be a thing for a while now, isn't it? 6 months. So, you know, is there, how can we still have those chance conversations, and, you know, what different things can we do to enable those, you know, corridor conversations? It is quite difficult. And if leadership and systems is all about relationships, maybe this is a slight barrier, isn't it?
yeah.
How do we break that down? There's just some stuff going on in the chat, just to let you know. So we're going to stay in these breakout rooms until 12:15, because there's been a bit of people have struggled to get out of the main hall into the breakout groups. So we've got a bit of time. So
can we move between breakout rooms, Graham?
Yeah, you can do if you want. Yeah.
So this one says making stuff better. Can you tell me what that's all about, please?
So making stuff better came from it was a conversation with Thea, actually. So when I was at LCH, we were trying to articulate what quality improvement was and is, and people were getting bogged down in you know, trying to define it to a minute detail. And I just said, well, it's just making stuff better, isn't it? And that's kind of stuck. So this kind of breakout really is around data. So, you know, being a data person, and Neil's helping on sort of outcome measures and things like that. And also his section was around that biopsychosocial model, you know, seeing the whole person. But then how can we prove impact? So, you know, we need to get a baseline, a bit like Melissa said. How do we get a baseline of where a person is when we start with them? Then we do some stuff, whatever that stuff is. How do we then measure at, you know, 6 months or a point in time, and then at the end of that intervention, if there is ever an end, how do we demonstrate impact? Because commissioners or whoever will always say, well, we've given you this bag of cash, how do we know what we're getting for our money? You know, but hopefully that narrative is changing, certainly in Leeds, where the CCG is changing itself to be able to commission for outcomes and commissioning for populations. So fingers crossed. That rubbish that always happens is, and as Thea said, district nursing, their target, you know, why would you need a target to see numbers of people in the community? It just makes no sense. But that's the way that historically the CCG in Leeds has commissioned. They've given LCH a big bag of cash to say, well, we need you to see 1,000 people this week. Well, that's no measure of quality, is it? Because you could absolutely game that, because you could send 5 district nurses to the same person on the same day. That's 5 contacts. But you could send 1 or 2 nurses who are trained in holistic assessments or a wider range of skills, but then you've only made 2 contacts, but the quality of those contacts is so much better and so much different to just sending folk up the garden path all the time. It just makes no sense. So there's been lots of conversations about, you know, and to be fair, that starts with NHS England, because they love to count widgets, and it serves no purpose. So I think what we're trying to do in Leeds is, how can we demonstrate change and impact in a different way? And that's where these outcome measures come. We ask people a series of questions, and yes, there is some element of a score, but how can we, with the things that we do with these people, how can we improve that score? And obviously you're not always going to improve a score, because some people might be end of life, for example, and it absolutely isn't appropriate to say you've gone from a 3 to a 5, you know, and celebrate that. That's not a thing. So anyway, that's slightly rambling.
So what about PAMs, patient activation measures? Are you going to be using them? Because that's what I thought Lisa could use with some of her projects, because I know that you've got some licenses in Leeds for that, haven't you? But then I don't think, well, they're not using that in our LCP, are they? They're using a different measuring thing or something. I don't know. So, like, in my mind, why are we not all using the same thing, the patient activation measures? You know, I don't know. There's no point measuring apples and pears, is there? So, if you're going to be measuring all these LCP outcomes, you'd think that you'd all have the same measuring thing. So, but in ours, in Birmingham, I don't know what they're using, but it's come from third sector organisation or whatever, so they're using their measuring thing. So I'm not saying ours is better, the patient activation measure or whatever, but it would be good if you're all standardising using the same thing, wouldn't it? Because how are you going to... So what's your plan for that then, Graham?
So what I think, so in terms of this particular program is focused around people living with frailty. So there was a big exercise engaging the system and people working in the system to try and put a framework of measures together. So there's 5 outcome measures. So the first outcome measure, for example, is around living, aging and dying well, around what matters to me, or when me is the person. So, and Neil can probably come in on this. So Neil did some, so it's really hard to measure. I think that's the overriding thing. It's really flipping hard.
Yeah.
And I think we just need to appreciate that nowhere else, no other system is doing this kind of stuff. So we're right at the forefront of this. And Neil did a load of research into try and find some measures that we could use across people living with frailty, but actually, as we've found out, we could probably use those same measures for other cohorts of people, just not children. I think that's true to say. So we do have a suite of measures that we can deploy across lots of different people. So it's the same framework, but obviously everybody is different. And I think that
are all the LCPs using the same thing?
Yes.
And so
yes.
what is that then?
So is
it like a PAMS thing? This is what I'm just trying to get in my mind.
It's similar.
I like
yeah.
to know things.
It's similar. So it's a series of questions, and I can send you some stuff on it, but it's a series of questions. So having building a relationship with the person that is in front of you in your cohort, and asking them questions. So there's one around kind of quality of life, and then there's another one around experience of health and care in the system. And those together are what we're going to use. There's also another outcome around how do you feel as a person, a professional working in this way in an LCP, because not only do we need to measure patients, or because they're people, they don't always have to be patients, they're people. We're measuring them, but also measuring you guys as well, you professional people working across the system and forging relationships. How do you feel about this? So that's also important. So there's a measure for that as well. So it is hopefully that kind of standard measure, but some LCPs and some projects are using EQ5D, they might be using PAMS. There's a project in the Hatch area that are using another, I can't just think what it's called. Neil might jog my memory. Something about a wheel.
A well-being wheel, I think
Well-being
it is.
wheel. That's it. Yeah. So there's a suite of measures that we can use.
So do you think that matters that they're all using different ones then, or do you think it doesn't matter?
I think at the top of the kind of the overriding framework, we're using the same ones, and those will give us measures across all LCPs that are
So how
using the same
are you
framework.
doing that then? Like, so you've got these measures. So how are you getting the data? Like,
Okay, so once a cohort has been identified within primary care, so as we heard earlier, some people have got between 20 and 100 people. So there's a template that's in development with data quality team. So within there is a method of recording that this person has consented to be part of this program. So there's a little read code that you can attach, and that flags them. You've had a conversation around sharing of data so that we can share their information with the third sector. There's also something in there, so there's a template for this Promise Global Health Score and the E3PC, I get it wrong, Q. So there's two templates in there that we can then, so it's all there ready to go, and the data is stored within EMIS or System 1. Then it's the job of us to pull that out at some point to do some work on it.
so what's it going to show then? You know, like with the PAMs, like if they've had an increase, they've got more self-management skills or whatever. Is yours going to show stuff like that then?
Yeah, I think it will. Yeah.
I've just tried to send the paper that went to the board that was basically kind of the whole kind of backstory around selecting the two measures. So as Graham said, so one measure is around, it's basically a measure of health-related quality of life. So it brings together domains such as mental health, social health, physical health in terms of if a person has symptoms, physical symptoms, what are their experience of those symptoms and their rating of those symptoms, and then also a person's self-report of their physical health in terms of their ability to take part in activities of daily living, and then it asks for a score of kind of that global figure really of their health related quality of life. So and then the second measure which Graham mentions was the P3C EQ, which is basically a measure of the person's experience of the care that they have been part of with the health and care system. Essentially, was it person-centered? Were they kind of at the heart and very much a partner in kind of the care that they were part of? And was it coordinated? So essentially, we know that people living with frailty, some of our more complex people, and as such they'll be touching different services, and is the kind of the coordination of that care. It asks for a rating of them. So I'm trying to send this document over to you, but it's blatantly not letting me for some reason. But it basically gives a little bit of a backstory about how it was selected and why it was selected. So I think what you mentioned before about the PAM score, which is a patient activation measure, that would very much...
Is it too focused on health? Exactly that.
And it's not that it's not a good measure. It's a brilliant and well evidenced measure, but the kind of the very kind of foundations of this frailty work is around that, as we mentioned before, about the biopsychosocial measure. So basically there was an ask that whatever measure and tool we use is broad in that sense, and it also speaks to different partners that are in an LCP really. If we're measuring something that is specifically health related, how does that engage someone who's from adult social care? And yeah, so that I'm trying to send this paper to you, and it's really annoying me. I don't know why it's not landing.
If you could send an email of those outcome measures, that would be really helpful, please.
And then it's just getting it in my mind about like time is one of the biggest barriers really in it, especially like for us clinicians or whatever. And then so you said you're going to be asking us things as well, is that right, Graham, like as part of your...
Yeah.
So how does that work? Are you going to just be asking people what work at PCN level like Lee said, or will you be asking people in practice?
So it's everybody. So everybody across every organisation, be it statutory or third sector, we want to get their opinion now, kind of at the start of this journey, and then at a point in time, we'll get people to respond to that again and again to see if we can evidence any change. So there's a link to a questionnaire around that, which we can recirculate. So would encourage you to fill that in.
I wonder how Nigel would have filled out his EQ5D or his P3CEQ.
Exactly.
Absolutely.
Exactly, Sab.
So, and that would probably bring out a whole host of different things, wouldn't it? I would think, but I'm not really familiar with these outcome measures, but we should definitely do that, because that would be a natural way of finishing our population health management work, really.
Yeah.
I think you raise a really, really important point, Sab, about how accessible is measurement to people, really. And I think I understand there's a commitment from the kind of the system, health and care system, to kind of systemize person-reported outcome measures, and kind of looking at obviously a large population in Leeds, and to do it en masse essentially to try and get some insight. And I think that's a really good initiative. But my concerns, and this is based on evidence from some of really, really brilliant programs in Leeds, like the SWIFT program, which looks at well-being for people that are socially isolated. An amazing program. They've got over 1,000 people kind of engaged with that program, and in terms of the measures, 200. They've got 200 people who have basically done a baseline and then followed up. Which, I mean, that concerns me a little bit, really, if just in terms of how we're able to engage with people and whether people actually want to be, engaging with measurement in this way, and really trying to unpick what are the best mechanisms to be able to kind of forge this measurement relationship, really. I think there's a lot of work that needs doing.
I agree.
We use the EQ5D in Bradford, and I will say that a lot of the patients didn't get the questions.
Yeah.
You'd ask them, they'd be really ill, and you'd say, out of 10, what is your score? It goes 0 to 100, but you had to explain it in 0 to 10 to half of them. And they'd say 100 when you got there on your first visit, and they didn't get it at all. And then some would be just, I know that some of the nurses were rushed, and they'd sort of fudge the figures a little bit as well. And I wouldn't have said it were an accurate tool to use at all, and it's people's perceptions of the questions as well. And then you go to some people and they'd be quite well actually, and they'd say 0, I'm 0, I feel awful, and that were it. And then you get 0 after 5 weeks, and you'd actually made a difference because the edema had gone in the legs. You'd given the diuretics, and I just don't think include health professionals and the public didn't really fully engage with it, if I'm honest.
Yeah.
I think there are things that can be more easily measurable than others, such as the edema in the legs, for example. That's improved. That's a measurement. You know, that is quantifiable. But it's the qualitative aspect is always a challenge, isn't it, with all of these subjects? So, but I think if you balance the two together, I think it would be good. That's why I think maybe a little bit more. Yeah, if you could send those, Neil, that'd be useful.
Yeah, I'm literally, if it cause I look a little bit glazed, Sab, it's because I'm just typing you an email now. So that's no problem. But I think what this is, kind of reinforced really is maybe that we, in terms of measurement, maybe we need to just kind of revisit this and communicate it better to the full group really about what the measures are, and kind of
It's only because we're hijackers. We haven't been a part of this, have we? We're from BHR, so we're just so everyone else might know this. But if I don't get things in my mind, I have to ask questions so I understand.
Hijackers.
And I'm new, so I don't know it.
Yeah, I'll get this sent over to you now, Sav. It's no problem.
All right.
But do you think so? Just thinking slightly outside of the box, then. So, if somebody in the system said, "How do you know that your particular service or what your job role is or what you're doing is making an impact?" If we didn't collect some data and we didn't measure, how would you evidence that?
You can't unless you do collect the data.
Okay.
And I used to hate data, me, Graham. I did.
Me too sometimes.
But I do realise how important it is, but I know how hard it is. I'm trying to find the right things to measure.
Yeah.
It's all really complex, isn't it?
It is, because you could say we'll just let it free flow and we'll do all this stuff, and then at some point we'll see some change. So, I did something yesterday around deprivation. So the gap between the richest and the poorest is widening. We know that, and there's an ambition in the city to close that gap or to reduce that variation. But how do you know that any of the interventions that you're spending taxpayers' money on, how do you know that that's directly impacting on closing the health inequalities gap? It is really difficult. But if you've got any pearls of wisdom,
yeah,
chuck it in.
If you can solve that, please, and then let everyone know about it, that'll be great.
All right, I'm going to just bounce out on this one, if that's okay. I'm just going to nip over across to, lovely to see you all, and I'm just going to hop over to digital or aging, but we'll see what they're talking about.
Nice
Thanks
to meet you.
for dropping that stuff.
Bye.
Bye.
See ya. So do we know if other people have got into the other breakout rooms and there's people in there?
There have been some problems. So there are people in all of the breakout rooms, but there are also people in the main hall that might have chosen a different breakout but couldn't get any of the links to work. But everybody is somewhere. That's a good thing.
Okay, good.
You're doing very well with these, Like I always say, this population health management one is a good one. How you organise your breakout rooms and all that kind of stuff. Yeah, I think we do very well. Well done.
It certainly worked so far.
Right, I think I'm going to go to main room then. Is that where Steve and Manraj are?
No, they are in one called System Leadership. It's Better Conversations in the main room.
Oh, I hope I don't get stuck somewhere I don't want to.
You can always sneak in and out. You don't have to have your camera on when you go in.
Right.
Manraj and Steve's is called Leadership if you're looking for it through the Teams tab.
Melissa, can I just ask just quickly? You mentioned about the risk stratification papers. You know, from University College London. You've just mentioned that a few moments ago. If I'm just going to drop my email in the chat box here. Would you be able to maybe forward me a link or maybe just direct me to them? Really interested in that, just for a separate piece of work.
See, there's a bit of a convo there. You know, one of them.
There you go.
Think I need to follow up on that?
Exactly.
Maguire Warner and Chess.net.
Yep, I'll send you it. Bye.
Thanks. Nice to meet you both. Take care.
Bye. Bye.
So the data and design room isn't cool and trendy.
No.
Or, Graham, our work is done.
Great job.
Our work is done.
Yeah, I think there is more work to do, isn't there?
On measurement, I think there might be, yeah.
But that UCL stuff, are you thinking about the long-term conditions?
So I'm thinking about the digital work, to be honest, Graham.
Right.
And just how, essentially, trying to evidence having an informed way or that the group can identify who might be in most need, essentially, in terms of the most need of health and care service. So yeah, just kind of interested to what that might have to say.
Yeah.
I think it's probably quite useful from some of those that have already started using those measures to find out what they are getting back, because I know at York Road are sending at least one of those questionnaires out to people, so they're having the conversation by phone, then sending a letter to people to let them know that they're going to have somebody contact them for a chat and a kind of holistic assessment. But with that letter, they then do get the first questionnaire. Now, I'm presuming if they know that the person might struggle to complete that, they'd maybe do it in the session. But I remember quite an extended conversation in board around at what point do you put it in, because if you leave it a bit, you've potentially got therapeutic effect going on. If you've got somebody talking through it with you, it gives a different result to maybe if you are just doing it in your own space, in your own time. So I guess it'd be interesting from some of those that have already started to get a little bit of that feedback to be able to then share with those that are just at the start of the journey.
Yeah, good point.
It feels clunky though, doesn't it? But it feels as though there isn't another way of doing it. And if there was another way of doing it, we would have worked it out, or someone else would have worked it out, and we would have been doing it.
Also, I think with any kind of person outcome measures, you've got, people will do whatever they do at the beginning. It'll be based on how they're feeling on the day, and they might be having a really good day or week or month, or let's face it, there's a lot of people in a very dark place right now with everything that's going on in the world. And then a few weeks later, they've got a therapeutic relationship built up. They maybe feel better or whatever, but they have no clue what they put in the initial questionnaire, which is fine, that's how it should be. But then they will try and cheat. They'll try and think, well, what did I put last time on that? Because I might not feel terrific, but I know I'm better than I was then. So it's not ideal anyway, is it? It is only, it's a bit of a feel for where people are coming from. And in that respect, once you do start amalgamating them up, that is where you maybe get a broader picture of, at the very least, how people feel about an interaction happening in the way that it does.
Yeah, and I really like the, I think it was either Rachel or Hannah Davies had mentioned about, in terms of evaluating and kind of evaluating outcomes, just ask people, has this been, like, not maybe something along the lines of, has this worked? Do you feel that what we're doing is working? And if it's a yes or no, just capture the yes or no. Or if you had to talk to somebody about what we're doing, would you talk positively or negatively? Just stuff dead simple and accessible like that has a place somewhere. Don't know how you systematize that, but I just think it's a really, really good approach.
it also fits, doesn't it, with that move in commissioning to saying, well, the more money we can give to people and communities and say, well, how would you spend this?
Yeah.
We have one idea of what we think is going to help, but actually, if you've got a different idea, then does it matter if it seems like it's off on a bit of a tangent, if ultimately it does achieve the same outcomes of that person feeling like their health has improved or whatever else?
Yeah. Yeah. I think on reflection, I don't think there was enough thought that had gone into accessibility of the measures. I think that's just my reflection on. Obviously, I was involved in the kind of the selection process and trying to find the right ones. I don't think there was enough on how accessible the measures are. I'm wondering whether, I'm just having a kind of reflecting out loud there.
We've got to start somewhere, haven't we? And Nigel, what Sab said about Nigel, he was spot on, and he made me feel shit, because how would Nigel complete that thing, But Nigel is important, and we can't just ignore Nigel and people like Nigel. But you're absolutely right. So maybe, I don't know, maybe you can't have a blanket approach to everything. Maybe it is this working? Yes or no? Are you feeling okay today?
Yeah.
And it's getting away from the traditional way of you must measure everything and you must be green in your RAG report at the end of the month and all that sort of stuff. It's more tenuous than that, isn't it? But can the system handle that? What's the word I'm looking for? The kind of the tenuous nature of, well, we're not actually sure, but we think it's okay, and people are telling us positive stories, so we're going to keep doing it. But would Tim Riley go, well, he's spending a heap of cash, and we're not, how does Tim Riley justify to anybody that he's given this particular program a gazillion pounds?
You still got expectations around health improvements, haven't you? It's being clear on the time frames on that.
Because it's not tomorrow, is it? We're going to fix it tomorrow.
Yeah, if you're doing that kind of public health, proactive, preventative type work, that that's not the sort of stuff that you see a shift on immediately or even necessarily in the kind of medium term. But if that is what you're doing, then you do need to have some kind of expectation of when would we expect to see any kind of real difference on these figures. So you might use something quite different in between time in how you engage with citizens and understand what is helping and working and what isn't. But also, are there some kind of key things and key givens that you do need in there as well? So I think it was Nadia Anderson that was saying the patient outcome stuff or the person outcome stuff is really important, and that kind of person-led approach to health. But at the same time, there's some things that are really important to keep people well, but they don't necessarily want to engage with. So some of those regular checkups around long-term conditions, etc., are not necessarily featuring high on people's priorities, but actually that might be the thing that gives them the extra years of life or the extra healthier years of life, just as much as addressing some of the issues around social isolation or employment or some of those wider determinants of health. It's those two things together. So, to be able to have the conversation about what it is about people's annual health appointments or whatever else isn't engaging. Is it the way that we do them? Is it the venue? Is it just that in the great scheme of everything that is going on in their life, this is bottom of the pile, and with the best of intentions, it's still being pushed to the sideline? You're still trying to get to that place. People are engaging with that, regardless of whether it's delivered in a different way to enable that to happen. So you've still got some tangible things you can count along the way, I think.
And I suppose you need that kind of that cover from above for senior, senior leaders to kind of hold their nerve and say, yeah, we're going to keep going with this. It's okay, and not go, actually, this isn't working. We need to go back. We need to stop all this fluffy stuff. We need to go back to, we must do it like this. So they've got to have confidence in it as well.
That's back to the experiments and the getting things wrong sometimes.
Yeah, absolutely. Yeah.
It was nice to see Harple's diagram there, Neil. He'd taken stuff to heart from.
I was so happy to see that. That was so crisp. Yeah. Yeah.
It'll be good to have some examples like that are shareable, though. There's a kind of bit of a toolkit that as different local care partnerships are advancing in different ways to each other. That it's like, oh, here's what Crossgates did. It might help you to then apply it to your cohort.
Yeah, absolutely agree.
And also the idea that he wasn't rigid about it, that it's kind of, I've sketched this out, this is where our thinking is right now, but we might change. Some of these boxes might look a bit different once we've progressed it a bit more, but we're at least starting to think through what it might look like.
Yeah, I think that's how kind of Otley have looked at it as well, is we've basically just gathered things and put it on a page, and then it's almost like around each one of them there's we're basically going to focus on each point essentially and just kind of flesh it out for each of those points. And I just think it acts as a bit of a guide really in terms of activity and what type of stuff that you need to do and kind of consider. So yeah, I think it's useful in that sense. What time are we reconvening, gang?
We're going to reconvene at 12:15, partly because the sessions that we'd kind of given an hour, the people like digital and better conversations, certainly better conversations, we're still trying to sort out the people that wanted to be in a different room at about 25 past. So I thought if they've prepared an hour's content, we need to give them as much as we can of that time, really. So
good shout.
Back at 12:15. Do you want to stop recording this one, Graham? Because I think we're probably done on content on this one.